This is Dr. Owen Brink, representing Blue Ridge Family Practice. I'd like to discuss with you the effects of buprenorphine, Suboxone, in the treatment of drug addiction, especially addiction to opiates. Buprenorphine effects. Consider 6 different colored padlocks: delta, kappa, U1, U2, nociception, and zeta. Each lock has a different function. Agonist agents fit into the lock, turn, open, and activate the lock or receptor. An antagonist fits into the lock but won't turn, open, or activate the lock or receptor, preventing any other molecule from engaging the receptor, blocking its effect. Buprenorphine is a mixed agonist-antagonist. It's a partial agonist-antagonist at the mu1. It does cause pain, result in pain relief. It's an antagonist of kappa. It has mixed effects on other receptor subtypes. Norbuprenorphine is a metabolite of buprenorphine that does have psychotropic properties. It blocks the mu2 receptor. There's no euphoria, no high. It actually blocks people from getting high. Eight milligrams of sublingual buprenorphine will give an 86% receptor blockade in opiate-tolerant dependent users. 16 milligrams under the tongue will cause a 94% blockade. 24 milligrams will cause a 97% blockade. This is the Suboxone or Subutex brand that comes in 8 milligram doses, 1, 2, or 3 tablets. The brain can tell the difference between 8 and 16 milligrams, 86% to 94%, or an 8% difference in receptor blockade. The brain cannot tell the difference between 16 milligrams and 24 milligrams, otherwise a 94 to 97% or only 3% blockade difference. However, 24 milligrams can be used short-term for acute pain syndromes if needed, such as after surgery. Remember, buprenorphine blocks the euphoric effect of opiates. They sure don't make heroin like they used to. Buprenorphine relieves and prevents craving, stops pain. It's actually used in open heart surgery for pain control. The receptor half-life is 30 hours. Plasma half-life is 3 to 5 hours, but it has a very high affinity for the receptor, which causes a much longer half-life. After the 16 milligram dose in 30 hours, 8 milligrams is still working. 30 more hours, 4 milligrams is still working. This is what a half-life means. This strong affinity for the mu2 receptor means that the bup receptor bond at the mu2 receptor is about 500 times stronger than the receptor's affinity for morphine. This means that a much longer time is necessary before the buprenorphine will randomly bounce off the receptor than morphine or heroin would. It should be noted that molecules and atoms sort of bounce around and have energy. They will eventually leave the receptor. The stronger the affinity the receptor and molecule bond is, the longer that receptor will be occupied by a given agent. This explains why having used bup will ruin attempts to get high by using heroin for more than a day after the last full therapeutic dose of buprenorphine has been taken. Transitioning from methadone to buprenorphine deserves special mention and review. Many methadone clinics put their patients on high doses of methadone, whether they need it or not, to control their addiction and/or pain. The best way to convert a patient from methadone to buprenorphine is to start when the patient is down to about 30 milligrams of methadone a day. The patient may need to be slowly titrated down to this level. It may take many weeks to do so. Methadone has a very prolonged and variable half-life of 8 to 60 hours. It's metabolized in the liver by the cytochrome P450 CYP-3A4 subreceptor types. It's metabolized by the same liver enzymes as methadone and buprenorphine. Converting the patients from daily methadone doses above 30 milligrams is possible, but the patient will be uncomfortable. This is unavoidable. Due to the long half-life of methadone in the body, it must be stopped for 2 days before it can be initiated. Even then, there will probably be some opiate withdrawal symptoms. Medications are prescribed to ease the various withdrawal symptoms that will be expected. Buprenorphine treatment should be started when the patient is in early or mild opiate withdrawal. Starting this medication while the patient has high level of other opiates, pain pills, heroin, methadone, can trigger opiate withdrawal or cold turkey type symptoms. Buprenorphine is not absorbed in the gut. It works well transmucosally across moist surfaces such as the inside of the mouth. It is best dissolved in the mouth, held in the mouth, with the saliva being not swallowed but swished around in the mouth, using the tongue to sort of paint the surfaces of the mouth, the cheek, tongue, under the tongue, gums, etc. Try to keep the drug-containing saliva in the mouth for at least 15 minutes. Do not smoke cigarettes or anything else before taking the medication and for as long as possible after the medication. Avoid brushing teeth before medicating and for as long as possible after medicating. Some toothpastes contain astringents which can lessen the absorption of the drug. To give an idea of the different forms, Subutex is pure buprenorphine. It's available generic right now. Retail cost would be about $4.50 a tablet. On the street, that would go for $25 to $40. Suboxone is the same medication, but with the addition of naloxone, which is an opiate blocker, which means it cannot be snorted or injected. This is the preferred medication type. It tastes a little bit better, and most clinics use this instead of the pure Subutex or buprenorphine. Cost is about $7.73, $20 to $25 on the street. Suboxone also comes in a film preparation. There's Zubsolv, which has a slightly different dose. It's absorbed a little bit better, and that's why it has the lower dose. It's a bit more expensive. Then Bunavail is also usually a little bit more expensive, not quite as much as the Zubsolv, and has a much lower abuse potential. As far as Medicaid is concerned, Suboxone film is their preferred agent at this time. Buprenorphine effects. Naloxone is a drug that's used to counter the agents, the opiate agents. It blocks all opiate activity. This is especially useful in overdose when breathing stops. It can restore breathing, blood pressure, etc. The Evzio autoinjector is available at about $3,742 per dose. Narcan in a vial would be available for about $65 a dose. The Evzio injector, however, is available on a compassionate use protocol. Most insurances will pick up the tab, and there are a variety of different types of programs by the company that makes this medication to make it available at a much lower dose.